Do you have any guidelines about, I mean, one concern I have on the patients I can remember is like, are we CAT scanning this person 3 times a month, and not finding anything? Do you have any like gestalt or things on your exam that help when they need to be re-imaged, when they're being seen for kind of the same thing over and over again and we're not finding anything? And
yeah, that's a tough one, because they're if you think about it, these patients are unhealthy to begin with, so something bad's going to happen to them eventually. And I don't want to be the one holding the hot potato when the music stops, so to speak. So the question is, do I just tell the nurse to scan them an 800 time, or do I try to maybe just get a white count? If the white count's normal, I'll send them to the clinic. I think that's how we used to do it. I think that's a reasonable option. If you got belly pain, you get a white count, the belly's soft, you document it soft, you can get serial exams, have them follow up if they can do that. The problem is, of course, then I always think back to Dr. Perez saying you got to image what hurts them. And so, if I'm going to do an x-ray, I might as well do a CAT scan, So yeah. It's a tough question. I know everybody doesn't feel that way, and I'm probably wrong about it, but that's kind of how I approach it.
Yeah, that makes a lot of sense, though. I mean, because they are not healthy at baseline. If there's a population that potentially is going to have the problem and it get missed, those are the patients that are probably high risk, just because of the bias that comes with them. They're seen all the time, but they're probably the most likely to have something emergent going on, and we're most likely to miss it just because we're coming into it somewhat unobjective, because we're looking at their chart, we're seeing that they're on narcotics, and we're seeing them all the time, and maybe the last 3 providers haven't imaged the body part that's hurting them, So I think that's a great point. Has your approach to the opiate overdose changed at all with your experience?
I'll tell you what, I saw that question. It's a good question. I'll tell you what's changed. The approach to the acute phase of overdose obviously hadn't changed much. I try to. I shouldn't say I don't give them Narcan. I'll try some Narcan. The nurses will give them that. If they don't respond immediately, I'm quick to intubate them, just because you got a controlled environment once you do that. But whichever way you fall on that pendulum, if you're going to, give them Narcan, wait, see if they wake up, that's fine. But what I've found is it's the next step that's changed for me and can be a problem, because I've Narcan people, they wake up and everything's fine then. They don't understand what the big deal is. They're ready to hit the road because they're wide awake. I remember we had this in the, I did my residency between 98 and 2001, I think. And back then, GHB was really big. And it was so short acting. I remember one day I was sitting there, we had a patient come in, he was on GHB. His Glasgow coma was 3 when he got there. I tubed him. I'm sitting over in the nurse's station like 10 minutes later, writing on the chart. I look over, he's sitting on the edge of the bed, pulling his jeans on. He'd extubated himself and he was getting ready to go. And I say that to say, where we lose patients, addiction patients, is in the delay between the emergency room and their definitive care, because you have a small window. As a recovering addict, there was a small window where, the light was shining and I was ready to get help, and I could see the damage that this was causing to me. But man, if you don't jump on that by Monday, they've forgotten all about it. They're off doing their thing, and the cycle just repeats itself. So I think it's very important. And I've kind of tried. We did this out in Colorado, and we do it here near Oxford. But we try to have a hot or warm handoff where we find a treatment center, or even if not a treatment center, a primary care person that will monitor any kind of medicine they need, will monitor their recovery, will monitor, getting them to treatment. If you can have an arrangement where they're contacted and even can come out. We actually would send some of the participants that have been in the program a while at our treatment center. When we get a patient, a call about a patient in the ER, we'd send them over and let them tell their story, show them they're not alone, and try to get them in immediately for treatment. And that's one thing. The other thing is, if you want to go the Suboxone route, the nice thing about it is you can give a multi-day dose at one time without having to deal with the prescription. And since it has a ceiling effect, it'll just release it over those few days until they can get established, if you want to go that route. But it's that quick handoff that's so important, I think.
Yeah. Do you start a lot of patients on Suboxone from the ER?
A few. If I know they're going to get good follow up and they express a desire, I certainly don't push it on them. But there's a few that if they want to get started, I'll do that.
Yeah, I think that's probably an opportunity a lot of us are missing. I mean, I think it probably is kind of hard to find that patient that's a good candidate for it, in the emergency department. Maybe they're not at that stage where they want to transition off opiates to Suboxone and get the follow-up. But I mean, I think there are those patients. I think we're missing them a lot of times. Yeah. Okay.
Well, the problem, of course, is, you got to have them in withdrawals to give them Suboxone. And so, if they come in, they just overdose on heroin. It's kind of, how long are you going to wait? You got to let the Narcan get out of their system, all that. You can't just hold them in the ER. But if you have a system set up where they can get immediate help, get locked in with somebody immediately, like we see on TV, these telephone numbers you can call to get to a treatment center. They'll swoop in, they'll get you a plane ticket, they'll send you across the country, wherever you match up. Well, kind of the same thing, but on a smaller scale. You want to act immediately. If you see them on Saturday and you let them go, they're not going to be, I guarantee you by Monday, they're not going to want help.
Yeah, that's a good point. I think understanding that narrow window that we have to act and get them that help is really key, because they don't have a whole weekend. We need to get them that close follow-up. That's a good point.
Yeah. And it's tough because of the, one of the questions you asked was about mental health in general, and it seems to me like mental health kind of got left behind when we developed EMTALA and all the rules we have for specialists and transfer. I can remember getting a little friction from surgeons back, when I trained, but now you call a surgeon with acute cholecystitis, they don't want to even give the appearance of not wanting to take the patient because they'll be liable. So you have these rules for how to get patients to the right place, except for in psychiatry. It's like psychiatry was left in the Wild West, and so there's no rules, and you almost are, unless you got a system set up, you're kind of left trying to find somebody and begging them to take this one case, and it's frustrating.
Yeah, I mean, most departments don't have a psychiatrist. I think I couldn't even tell you what the hours are that we would have somebody in our department, because it's so infrequent. I feel like we rely on our social workers, our mental health evaluators to make a lot of those decisions, and they do a great job. But that kind of brings me to another question about, the M1 hold, or the various types of holds that states put on people. From your experience, do you feel like these holds are helpful for people, maybe just in some scenarios, or do you have any opinions on those just in general?
Yeah. So, I would say from somebody who's in recovery, they're worthless as far as trying to force somebody to get better. It doesn't work that way. It's, we hear it all the time, but I can't overemphasize how true it is. If that person's not 100% desperate, you're spinning your wheels. They got to be desperate, realize they're on death's door and ready for some help. On the other hand, you got suicidal, genuinely suicidal patients and other psychiatric disorders that they will harm themselves if they're let go. And so in that case, I think it's important to have that tool available. I know it's interesting. I haven't, I didn't think about it until I saw the question, but I'd be interested to hear from other states on how they do it. I assumed it was all the same. When I was in Louisiana, if you had somebody that mentioned the word suicide, you signed that hold. As soon as you signed it, that was a guarantee. Whatever facility you called, they had to take them because they have, this whole. But in Mississippi, it's different. They almost will never take them if they have a hold. They'll only take them if they don't have a hold. And I'm not I'm not clear on why that's the case. You would think that the hold would allow them to take them easier.
Yeah, I think my department has a pretty good system. When they come in the door, we put them on kind of a temporary hold. They're not allowed to leave the department until they've been evaluated sober by a mental health evaluator. And then those folks do a lot of the legwork. They'll call family members. They'll figure out who brought them in, who else was concerned if it's not the patient. And they'll do a lot more time with the patient to figure out, are they actively suicidal? Do they have a plan? They dig in a lot more into the nuance than the providers have time to dig into. And then they will either come back to the clinician and say, yeah, we agree. They need to stay on a hold. We need to keep them inpatient somewhere. They're actively suicidal. They have a plan. They have guns in their house, whatever the case may be. Or they'll come back and say, hey, this patient is clinically sober now. They're denying that they're suicidal. They have great family support. We're comfortable sending them home. And often we defer to their plan. They do a lot more of the nuanced work than we have time to do. So often they will take them back off that hold and we'll release them with a plan. And they're really good about making sure they have follow-up. And so when we put them on that initial, I guess, temporary hold, it doesn't always mean that we're keeping them for 3 days or whatever the case may be. But
yeah, that's good. That's I wish we had something more structured like that. I always I run into situations like that all the time, and I'm scared to, because they got the word suicide on the chart, and maybe this is just me being self-protective, but I'm scared to renounce that. How do you explain that? Because if something happens, they go out and something happens to them, it's going to look like you let a suicide patient go. But if you've got a system like you do where you had somebody officially evaluate them and declare, I would say that's as good as having a psychiatrist do it.
Yeah, it's very helpful for us. And often, that's a situation. They're in the emergency department for, 8 hours or oftentimes a lot longer as they sober up from whatever the substance is. So it's a very slow process that we have to wait on. But I feel like it does allow us to disposition them safely, and every now and then we'll disagree with the mental health evaluator. We'll be like, well, when they came in, this guy said he put a gun to his head at home. I don't agree that now that he's sober, he's not a threat, and I'd like to keep him on the hold. And that's more the exception than the rule that we disagree with them. But that does happen sometimes where we're worried enough about the initial story, even if they're not 12 hours later, they're not as worried about them. I'm still worried about them, and we still keep them on a hold. But
yeah, that's a good process, definitely.
Have you seen any success stories from your patients from the ER, either starting them on Suboxone or any patients that come to mind that you feel like you've been able to help from your frame of reference more?
Of course, we don't see, I guess some guys follow their patients. I'm not one of them. Once the patient leaves, I don't really, I'm moving on to the next patient, but, so I don't see a lot of that. There have been a few cases though, and I'm not sure they're necessarily a success because I'm not 100%, but I think they've gotten some help. We have a place in town with it's basically a treatment center, but they deal with other life problems, but it's inpatient. And I had a guy that kept coming, and he's example of what we see has blown off as a frequent flyer. He'd come every week. The nurses would laugh. They'd say, "Oh, he's circling the ER." He'd circle around the ER for an hour, and then he'd finally check in. And he always had these vague complaints. And so one day I went out to his truck and just talked to him for a while. And what happened was he probably wasn't having anything somatic wrong with him. He was by himself in this big home. His mom had died, and he was drinking beer all day, and he was just depressed. And so I was able to offer him some resources as far as what he could do to help. I shared a little bit about what had helped me. And I honestly don't think I've seen him since then come in the ER. I've seen him around town. So I don't know if I scared him off or that was actually beneficial to him.
Yeah, I think that's one struggle we have in the emergency department is we don't really see follow-up. There could be patients we're legitimately helping in a lot of these scenarios, and I wouldn't know it until you realize you haven't seen them in a few months, and maybe they're doing better, maybe they're in another hospital system and they're out of town or something, but it's so hard to know. Sometimes the things we do make a huge difference and we just don't know it because there's no ability to follow up with these patients.
Yeah, that's right.
Is there one thing in particular that you wish every ER doc or PA or NP knew about psychiatric emergencies, kind of having dealt with some of that yourself?
Yeah, the message I would communicate is kind of what we talked about before, of having empathy, slowing down with these patients, because here's the thing with psych patients, at least my original thinking, when I'm going through training, I'm thinking about, well, the people that are about to drop dead, I really need to learn how to fix them because they're about to drop dead. And then you got the other ones, people having heart attacks, they're not dropping dead, but they're critical. And then I kind of go on down the line. Well, psychiatry is kind of, I think in a lot of ER providers' mind is, as soon as they say I don't know, anything suicidal, hearing voices, it's like immediately, it's not an emergency. Our decision, our job is to determine stable and unstable. And as soon as we hear that, we're kind of put them in one camp. But I would love to see, and myself included, more empathy towards these patients and taking the time to really, it may not be chronologic more time, we may not have that, but making a genuine effort to figure out what's really behind these issues rather than just shuffling them out the door. Now, of course, if they're getting good psychiatric help as a result of your placement or whatnot, that's fantastic too. But I think I've been guilty of not taking them as seriously.
Yeah, absolutely. I have for sure. Is there any practices you have in your busy day to remind yourself to be compassionate for these folks and retain a level of empathy? I mean, we always talk about in the ER, you can't have empathy for every patient that comes in the door. You can't take on their burdens as your own, or that's going to burn you out, substantially. You can't take on every emotion that the patients are having, but I think there's room for a level of empathy and compassion with these people that doesn't burn you out and probably actually makes you more fulfilled as a clinician. And so I think there's room for empathy. It's not that we need to completely avoid that, just see him as a patient. We're not seeing him as a human. Do you have any practices, I guess, throughout your day to remind yourself that this is a human you're dealing with? This isn't just another patient to move down the chain, to kind of help you get to that level of understanding with them? Yeah.
I struggle with that. Just like any ER doc, and the busier we are, the harder it is. But what I've kind of learned to do, and I may be the latecomer, everybody else may already be doing this, and it's not a surprise. But I try to either ask the family or ask the patient something personal, like, "Hey, do y'all live in town?" or "You going hunting tomorrow? It's the first day of duck season," or something to get the conversation started in a personal manner. And for me, it seems like all those things you mentioned kind of come to life when I do that. The outcome of their medical problem is going to be the same, but I feel more fulfilled about it. Just knowing a little bit about the patient, and I guess maybe there's some pride in hoping that they will see me as a person and not just an automaton or something.
No, I love that. I think small things like that do make such a huge difference, because you want to just ask the questions that you need yes and no answers to oftentimes and then move on to the next patient. But if you can ask something that doesn't really guide your practice, but allows them just that little window to open up. I had a pastor on the show a few months back, and he would ask the patient's full name, and he's, in and out of the hospital just as a pastor dealing with end of life things. And he would ask their full name. He wants to know their middle name, their last name. And then he kind of asks them well, why did your parents name you that middle name? Or what's the significance of this name? And it just be a small little thing, but it kind of takes the patient off guard, and it makes them feel like a human for just a brief second, as opposed to a number or just a patient you're moving through the department. And I think small things like that for us in the ER that are not time consuming are really key, because we don't have a half hour per patient. We can't sit there and hear their entire life story. But if you can ask something that's, a little relevant to their social history, I think it gives them just this little opportunity to open up to you a little bit more.
Yeah, that's beautiful. I tell you one thing, it reminded me of something my dad taught me, and I can't really use it in the ER. I haven't found a way to use it. Maybe I need to be more proactive. But, he came up, of course, they didn't have computers. Everything was on charts. And so when he would go see a patient, they pull the chart out of the door and thumb through it and talk to the patient. And he would always have inside the inner folder, he would write down little notes like 2 children, Marie, and whatever. And so when he walked in, it would look like he genuinely was focused only on them. He'd say, "Oh, how's Marie?" And so, so and so. And it would look like he took enough interest to learn about their family. And then, of course, they feel more comfortable then. And if I could find a way to do that, I would do that. That sounds like what that pastor does. That's fantastic.
Yeah, and he's got the nice benefit of being able to spend a lot more time at the bedside than we do too. But that's why I think the small things actually make a big impact over time for us. Something that doesn't take a half an hour, something that just takes a couple minutes to humanize the experience, I think, for them. Having dealt with addiction so much yourself, is there things that we are consistently missing on these patients in the ER, would you say, or opportunities that we are pretty consistently missing?
In regards to their diagnosis and treatment?
Yeah.
Yeah. The thing I think about is underlying. When I got somebody that I'm tempted to blow off, or my antennas really go up when the nurse says, "Oh, here's another, Miss So-and-so's here again." I could tell they're not interested in digging too deep. That's kind of my cue to look further than just, the drug seeking or whatever the superficial complaint is, that, there's something causing that. And, if I could dig a little bit and find out what that is, maybe I could offer them a little more help than they were usually would get.
I think that's a great practice. I think when you see that the nurses or the EMS crew that brings them in already has this bias in place. It's so-and-so again. We picked them up 3 times today. They're coming back in. Their complaint's ridiculous. I think that should be a flag in our minds as the clinician to be like, we could be missing something. I mean, we've all probably had the patient that's heavily intoxicated. They're here every day for alcohol intoxication, and this time they have a head bleed, and you're more likely to miss that when the EMS crew brings them in. We found them stumbling around outside. They can't walk well enough. So now they're here, they're just drunk, and you look in their chart and that's what they're always here for, but you just do a little bit better exam and make sure they don't have any traumatic injuries. I feel like when there's so much bias being passed by everybody else in the system, that should be a red flag in our minds to take an extra step, do a better exam, and make sure we're not missing something, because those are the patients we miss things on for sure. Yeah, I try to practice that a lot when the crews, and I was a paramedic and EMT before, like I get it, you're picking up a lot of intoxicated people, but I try to order a little bit more than I necessarily would when I feel that bias coming off of people, and I try to express that to the crews, like regardless of how many times you've run this patient or whatever bias you're bringing, try to give us as objective a report as you can to help steer us in the right direction. We don't want to hinge on that one diagnosis that may or may not actually be true. That anchor bias can be so dangerous.
Yeah. So as I mentioned, I was a pilot before I went into medicine and loved it. Was a commercial pilot, flew some charter business. And there's something that's caused a ton of big aviation disasters, specifically with airline planes, called confirmation bias. And it's where you get this idea in your head that something's going on. You feel it. You're sure the plane is going a certain direction. So you only look for things that confirm that belief instead of really reading what's actually going on. And I think we have that in the emergency room too. We want things to be a certain way. And so we kind of tailor it so that it matches up with that. And then when it's not, disaster strikes. Yeah,
that's a great analogy. I think, yeah, and we all fall victim to it. We've all had patients where we probably miss something on because of that. So it's a good check to remember that even you can't even trust your gestalt. No matter how long you've been in medicine, you can't always trust your Gestalt. It'll lead you astray. We can all probably think of scenarios where that has led us astray. And so I think that's a good check to always have.
Now, I'll tell you something else I've learned. I didn't realize this, but as I've gone through the, I guess the latter half of my practice or whatever since my recovery, I've tried to, as we talked about, I've tried to take more time with the patient, be considerate, ask, I'm gonna give away a little bit of negativity about myself, but I used to try to get out of there without asking if they had any more questions, and I know most doctors do that, but just sitting there and making sure, have a little silence after you ask them if they have any more questions, and make sure they don't feel like you're running out. What that also does is I've noticed even the most callous ER nurses I have, and they'll still gripe about them, kind of in the nurses station. But when they go into them, they've got a much softer tone because they're following your lead, So I think it's, we've got to be the ones to pick up the mantle, so to speak, and lead, because they'll usually follow where we direct.
100%. Yeah. I love the question at the end. Do you have any further questions? And actually pause long enough, not be walking out the door when they haven't said anything, but just pause long enough for them to actually ask, because they probably do have additional questions. We think we're giving them all the information because from our perspective, it is enough, but they often bring up a worry in that moment where they're, maybe they're worried about a stroke and they're there for chest pain, and we're not worried about a stroke at all, but that's what they're specifically worried for. And it gives you that opportunity to actually reassure them, hey, none of these symptoms are a stroke. You're not having a stroke. That's why we checked out a bunch of your heart stuff, because we're worried about this being a heart problem. And then it actually makes their visit much more fulfilling for them, even if we don't have that clear answer, because we often don't have a clear answer, when we're discharging someone. We're just making sure they're safe to go home, and a lot of times they don't understand that. And when I see patients in combination with a physician and they ask that question at the end, I'm like, oh no, we're going to be in this room another 5 minutes now. I was ready to run out and go do something else. And you ask the question, do you have any more questions? I'm like, oh no, but I try to incorporate that because it is so tempting to not ask that and assume that you've given them all the information. And usually we haven't probably given them all the information that they wanted. I love that. That's a great question to end with, I think.
Well, we're talking like we have all the answers, but I mean, this is a process, we go through, and sometimes I fall back a little bit, and I got to, regain my footing and kind of remind myself what I need to be doing and why I'm here. And hopefully overall I'll move forward with it.
Yeah, I think we're all working on that. I mean, I think, most of us work in high volume centers. The ER is the catch-all for everything that healthcare in general is missing. And so often we're the people that deal with the primary care. They can't get in with their primary care. They can't get in with this specialist or that specialist in a timely fashion. And it's not their fault. It'd be great if they could get in and they had insurance and everything was perfectly covered, but we're the catch-all. And so I think, giving them that opportunity to actually express their concerns is so key.
Yeah, absolutely.
Are there any big systematic changes that you think most ERs need to incorporate that they're not already incorporating?
Well, I know from my little world, we've tried to get the doctors together on how we're going to approach these patients. Specifically the attention seeking and the attention gaining patients. Because if you got one guy, we had this, he's since retired, but we had a doctor that, if you complain of a stubbed toe, you were getting 75 of Demerol and, 25 of Phenergan. And so we've kind of tried to come together and agree on what we're going to treat, what we're not, because, if we're not all on board, they're just going to keep coming back till they find that one person they like, and that sounds a little callous, but the idea is we're trying to find the best care for the patient, and not just say nobody gets anything. We're gonna be ugly about it, but that this is we all agree this is the best course in general to take.
Yeah,